Hello, I'm Dr. John Kruse, and welcome to today's question and answer session hour. So I will be trying to answer questions on the topics of the two videos I released this past week. I'll get into those in a moment, or on any general ADHD topics, or even broader mental health questions. So thanks for being here, and thanks if you're a subscriber to the channel for subscribing. Before I move on, I'll give a special shout out to Apprehensive Dish, who's been helping promote the Reddit Reddit subreddit, and raise my profile and online. So that hopefully is good. So the two videos released this week, one was on ketosis, that was a re-recording, and my participation in the ADHD Entrepreneur Summit, where I talked about scheduling, was also made available to me, so I can post it on my site. In terms of ketosis, our bodies generally rely on glucose, a simple sugar, for energy source. In situations particularly of extreme carbohydrate deprivation, we start burning fatty acids and produce ketones, and that can be detected in the blood. And that changes a fair amount of cellular biochemistry, so that there's some decreased inflammation, there's differences in oxidative state and damage to different parts of the brain. Chris Palmer has made a career, a Yale psychiatrist, about promoting the idea that all mental health problems are stemming from problems with cellular metabolism, and that states of ketosis can be helpful. In terms of ADHD specifically, there's a moderate amount of anecdotal information. If you go online, people claiming the ketosis diets help them. And as of today, so no change from when I made the original recording, I think more than 2 years ago, there's not a single study formally looking at ADHD to see if it is improved by ketosis. So it doesn't mean it can't. And the other thing to mention about ketone diets is that people vary tremendously in their individual response or ability to enter ketosis. So just because you are carb restricting doesn't necessarily mean that you are in that state. So blood testing is, as of now, probably essential for verifying that. Regarding scheduling, I look back, scheduling was actually the very second video I made. So some of my thoughts there were repeated in this interview. My big push is that half of the battle with scheduling is just accepting it. And many people with ADHD say, I'm spontaneous, I'm creative, this is me, I don't want to destroy that, and then complain that they're not producing or getting anything done, and everyone's angry at them. So I would say that instead of viewing scheduling as this evil galley ship master who's making all the people stroke faster, what is a schedule? A schedule is aligning what you are doing in the moment with your own life goals, life values. So it is the kindest, gentlest, nicest, smartest part of you that's made your schedule. And the metaphor that I come up with is, imagine it not like the galley master with the whip, but it's the mother hen who's counting and arranging the chicks all around her before she hunkers down and takes care of them. So the other things I say about scheduling is put in the 4 basics first, put in sleep, meals, rest time, and physical activity. And when it's time on the schedule for you to do something, try to get in touch with why you want to do it, not why you have to, should, need to. So I'm happy to talk more about scheduling, but that's the brunt of that discussion. So I see there's a lot of questions already coming in. And so I'll hop to it. And I did read in advance James's question. That's the first one there. It's how important is the cerebellum in ADHD? And he's seen many people doing balancing exercises, which they say activate the cerebellum and helps with ADHD. So it is a good topic that's been on my list of things to do more research on and talk about. I won't pretend to have any proficiency with knowledge of what the cerebellum does with respect to ADHD. I know that there's some evidence that's showing sometimes cerebellar damage can result in ADHD-like symptoms. I still believe that most of the evidence shows that most of the core symptomatology of ADHD is prefrontal cortex executive functioning issues. That doesn't mean other areas of the brain may not be interacting with that part of the brain and able to muck it up. So that's a very imprecise answer, but it is on the list of things, and this has probably boosted it a little higher on the list of things for me to investigate more thoroughly and talk about. So, hello, Max. Good morning or good evening for you. Max asks, how much of the benefits of scheduling is learning to deal with and accommodating your ADHD symptoms compared to actually diminishing your ADHD symptoms thanks to the effects of the scheduling? So it's a good question. I'm not sure anyone's tried to parse it precisely. I mean, at heart, even though I have a PhD in neuroscience and I'm a scientist at heart, in my real world, I am more a pragmatist. So if something is working, great, and then we can try to sort out or parse out why it's working. And I think both factors are involved. So I think there's a little bit of evidence that any habit you practice. So if you practice, time awareness for one thing, we know that measurably people with ADHD are less accurate at measuring how much time has been expended on a certain task, or how much time has been expended on no task at all. If you put them in a dark room with no watch and buzz them after a certain interval, and it's not that they're consistently short or consistently long, that they're consistently inconsistent. But if you practice that, so I think part of scheduling is practicing and training your brain to look at, okay, what do I have to do for the day? What do I have to do for this hour? How do I get back on track if I've lost track of it? How do I put in place? So some of it is putting in systems and reminders. So the schedule itself is a reminder, but also backed up by potentially whiteboards, potentially an open calendar on your computer, potentially alarms or reminders electronically sent to you, potentially you're training your social network or your colleagues or your underworkers or overworkers to remind you and not nag you about certain things getting done. So I think some of it is learning to deal with and find systems for your ADHD, and I think some of it is, again, when we say someone has X amount of ADHD symptoms, and ADHD clearly exists on a spectrum, someone isn't locked into one point on that spectrum for any specific executive function. It's a range of behaviors that you're in. And even if you're at one end of the spectrum, going from the extreme end to further closer to the mean may be a measurable, significant improvement in your daily functioning or your lifetime functioning. So Frank is commenting that he's noticed a small Coke. I'm hoping that's Coca-Cola, not cocaine. Midday works and zero caffeine are full of caffeine. I'm not quite sure are full of carbs. Oh, okay. So Frank is getting back to the sort of the ketosis issue, and that both the combination of caffeine and caffeine with no carbs, as he feels, is particularly helpful for them in the middle of the day. So Dmitry Sokolov is a persistent 5x productivity gap between structured settings like office, classroom, and home settings, something you often see in ADHD. So one is I like the precision of 5x. I like trying to monitor or measure things. I would just sort of question, how do you measure productivity in a work setting or a structured setting, a classroom, an office, versus presumably maybe a more fun or relaxed setting where what are you actually producing? But but I guess Dimitri's actually asking about specifically home environment and work. So let's pretend it's a question about home office versus in office work with others. And yes, if there's persistent differences, that is at all uncommon in ADHD, that the surroundings, the environment, ADHD has to do with the capability of functioning of executive circuitry in your brain, but that's always operating in an environmental context. And if you find an environment that has enough reminders, that has enough reinforcement, that has enough structure without being too annoying, too intrusive, too directive, then you're going to function better than in a situation where you're not getting the support that your brain needs. So yes, I would say that is consistent with ADHD. Now, could there be other explanations? I mean, one certainly could be an anxiety one. If there's something in your home environment, whether you're aware of it or not, that's triggering, that's reminding you of some stressor that's distracting you, then that could be part of the explanation. So Dennis is asking, excuse me, if a person lives in a country where prescription stimulants are unavailable, could they use coca tea to treat their ADHD? So most stimulants will have some beneficial effect in a majority of people with ADHD. I don't know of any rigorous research looking specifically at coca tea and using that to treat specifically ADHD, but it would not surprise me that it could be effective. Whether the potential adverse effects, either cardiovascular or propensity for psychotic reactions or other things, counterbalance the benefits, I don't know. But again, I mean, the most widely used psychoactive substance on the planet, caffeine, is certainly a non-prescription in most areas approach that measurably can help ADHD, and other natural stimulants are likely to as well. Max says, some people with ADHD sometimes stop taking their stimulants so they can, quote, feel more like themselves. His experience is the opposite. It would make me feel less like myself. Have you observed one or the other? So I certainly see both happening, and far and away more often. And I'd like to think it's because I'm adept or skilled or practiced at helping people find the dose that's optimal for them. And optimal, I don't think means necessarily most improvement in cognitive executive functions. I mean, optimal meaning what feels comfortable and what works and helps them feel more like. So very often, and I see it also with depression. I mean, people say, oh, antidepressants cloud you, they take away your personality, they make you numb into a zombie or a robot in society. And far and away with antidepressants, the answer or the response people say who have been depressed is, wow, I feel more like myself than I felt in months or even years if their depression has been going on for years. And similarly with ADHD, I hear people say, wow, the ideas I've had, the creativity, whatever I'm doing in music or dance or writing or art or my own coding or programming, I feel one is I'm getting much more done, and that helps me feel more like my true self is being expressed fully in a way I can express it. Now, certainly I have seen people with ADHD medications who do feel, yes, I'm more productive, but I'm feeling driven. I'm feeling my normal motivations aren't the same. It's a different something driving me. I've certainly also seen some people with depression who felt numbed out by those medications. So that's what I would have to say for that question. Come on, anyone? I see there's at least a dozen people out there listening. So Max asked again, or another question. I often see a quote used in various forms that says, The brain uses up to 60% of one's daily energy and or calories, despite being only 2% of the total body mass. Is there any truth to that? So the simple part of the equation is 2% of body mass. That's about the case. I mean, people vary in size, but the brain is a few pounds of material, and its energy. So its energy use is certainly disproportionate to its volume. The numbers I've seen in more rigorous or I think actual studies are not quite as high as 60%. What I've seen is, that it's a bigger consumption of energy or drain on energy resources than any major muscle group in the body. But I will have to go back and check whether 60% to me sounds high. Part of it is just basic metabolic needs. I mean, even resting muscle is expending energy, again, less per gram than brain, but you have a lot more mass in muscles. So I don't think it's 60%, but I will try to check and get back. And I'm writing it down. And maybe someone else can check even as we're talking. So Dimitri's saying they don't have a question, but regarding measurements, Dimitri uses an app to track what he does on his computer. The app is Rescue Time, and he has about 10 years of data showing that he codes about 5 more times in the office than at home. So one, probably my biggest weakness as a clinician is not being as attuned. I know there's good apps out there. I know part of it is that, as with referring books, people often ask me, what's a good book for cognitive disengagement syndrome, or what's a good book for amphetamine-induced psychosis? And I don't think there's a good book on the psychosis. But books have to appeal to you, so it doesn't matter if it gets a 90% rating on Goodreads, or if I think it's really clear and articulate and evocative, if the writer's style doesn't speak to you. And similarly, if the font, if the color, if the system's superficial appearance, or if there's one tiny feature on the app isn't what you want or annoys you in some way, then it may work for most people, but it may not be a good app for you. And particularly in the space with helping with executive functionings, there's so many options to choose from, many with overlapping capabilities. I'd say don't get bogged down in trying to find a perfect app or option. It just has to be good enough. So Max is also encouraging anyone out there can ask multiple questions. So Max asked, do I encounter situations when first titrating up for ADHD, leading to the patient getting their lifestyle factors in order, leading to lowering the dose? If lifestyle gets disrupted, do you up the dose? So to me, far and away, the biggest single lifestyle factor is sleep, and getting, again, not just enough sleep, but getting consistently at the same time of day, because it's the same duration, let's just say prototypical 8 hours at a different time of the day is not as restful, not as restorative. Probably there's also a small body of evidence that desynchronization of circadian rhythms is particularly detrimental, and some people believe it's the underlying contributor to ADHD. So I've certainly had people who were on a dose of medication, and actually the medication helped them stabilize their sleeping. And once they were on a good sleep regimen, they were able to lower their dose. I'm probably drawing a blank with specific other lifestyle. I've certainly seen people feel that they were able to improve their lives overall, and or find a job that was a better fit, or find a partner that was a better fit. And then very gradually over time, had less of a need or a need for a lower dose of medication. And there, it's really hard to pinpoint which individual factor, and it may be whole lifestyle differences. So yes, I've seen people do better and then be able to decrease their ADHD medication, or in some cases go off of it. So the second question is, when lifestyle factors get disrupted, do you up the dose? And I think at a societal level, this is actually what we were seeing during lots of COVID, when we saw surges in adults, no particular surge in kids getting diagnosed with ADHD, but surge in adults, many of whom were on the spectrum before and were just less able to function once their structures at work, their structures at home were more disorganized, less helpful. So I think many people first came to treatment and then got put on medications. And I've certainly had people in similar scenarios where they were laid off, or so they weren't going into the workplace, or again, during COVID, they had the same job, but kind of like Dimitri mentions with his coding being fivefold different at home, particularly since I was on the edge of Silicon Valley with a practice in downtown San Francisco, or the middle of San Francisco, not the downtown of San Francisco. It's not just the structure of seeing other people, having your boss looking over your shoulder, having your coworkers remind you when to go to lunch, but many of these Silicon Valley big companies, they weren't just having the social reminder to go to lunch. They had a gourmet, nutritious, delicious meal available at their access. They had gym resources at their access. They had relaxation pods and sleep pods and meditation classes at their ready disposal when they were working on site, and lost all that when they had to work from home. So yes, I've seen it be helpful to have a higher dose of medication when social environmental disruptions exacerbated ADHD symptoms. On the other hand, sometimes those disruptions increased anxiety, and in that scenario, increasing most of our ADHD medications, if in the setting of increasing anxiety, is counterproductive and often makes the anxiety worse, and then can make executive functioning worse as well. So Dennis recommends one of his favorite ADHD books is Stimulant Drugs and ADHD, Basic Clinical and Clinical Neuroscience by Castellanos et al. Incidentally, Castellanos was one of the people cited in the New York Times Sunday magazine article that came out. I think it's almost a week and a half ago now, maybe 2.5 weeks ago. I know Russell Barkley has commented extensively for separate videos pointing out numerous factual errors in that article. I only skimmed the article, and my take on it, I certainly concur with every single point that I listened to in Dr. Barkley's critique, but my overall take on the article was not as vehemently negative. I think there was and I think part of it, and I should go back and read the article, and I may do my own video. I think part of the difference is that Dr. Barkley is one of the most intelligent and experienced researchers in the ADHD realm, and the realm of ADHD researchers is not exactly the same realm as the ADHD treatment community. And I think the author of the article makes no distinction between the two, but sort of talks about what's ADHD practice and sort of attributes that to ADHD research base. So I think the researchers on ADHD know more about ADHD research and what's been done. And I think some of that isn't always translating into what's being done in clinics or in individual doctors' offices. So I thought the emphasis, I would actually agree that overall, Russell Barkley and Margaret begins with an S. Sibley. And many others have done extensive research, showing ADHD symptoms exist on a spectrum. People wander back and forth across the spectrum if we do have an absolute cutoff. So yes, that research is there. And yet in the ADHD community, particularly since it's so tied to identity, many people see it as a categorical entity. I have ADHD, you don't have ADHD, your attention problems are just simply an occasional off problem. And how we map out the individual identity element being categorical for many people with the concept that ADHD exists on a spectrum, I'm not sure how we resolve that. So that was the tie into Castellanos. And if any of you think that it would be useful for me to do a video on commenting on that New York Times article, let me know. So again, what I think is that it is good and valuable to be emphasizing the spectrum concept. That's part of the book I'm working on. So maybe that's why I was more open to the author's approach, again, even though I do concur with Dr. Barkley that there are numerous, I would say, distortions and inaccuracies. But I think some of the overall big message was there. And I need to read it more closely. My impression overall was it was not particularly, given the New York Times has published many things quite in opposition to the ADHD community or the existence of ADHD or that it's all overdiagnosed. I thought this was a more balanced and reasonable article than some of the others they've done historically or authors who've worked with them have done. So Max asks, how do I feel about the claim that Ozempic may be one of the biggest medical discoveries in modern history in terms of positive impact on general health? I'd say we'll need to see that. I mean, clearly, obesity, overweightness, obesity has specific definitions, but people certainly are running into a myriad of health problems, not just mobility, not just joint, not just impact on their heart, being overweight. And I'm aware that there's a strong body positive movement and appreciating people's individuality, and particularly that we shouldn't be stigmatizing people, but there are, particularly growing evidence shows that having excess fat on your body is a major contributor to hyperinflammatory states, and hyperinflammatory states are a huge problem, not just as a contributor to dementia, but contributor to a multitude, depression, probably ADHD, probably a host of other mental health conditions as well, all cardiac issues, all autoimmune problems. So being the overweight epidemic is huge, and some evidence suggests it's having a bigger impact than smoking, a bigger impact than some other unhealthy habits humans have. So if we had something that treated part of that, some of the objection, though, is that you're not treating the obesity epidemic at its source. You're going downstream and trying to counteract it. So I don't see it likely being the full answer even to the obesity, overweight, too much fat in the body part. I think it can be hugely helpful. The other thing is these drugs do have other effects in addition to just helping with glucose metabolism and helping with weight. And in some people, and I do have a video on this on Ozempic, they certainly in some people have pronounced effects on the brain and changing what people are satisfied with or satiated with or what motivates them. But it's striking how inconsistent from person to person some of these effects are. So Max is asking another provocative question. Good. Max is repeating that some psychiatrists make the claim that a parent denying stimulants to children with ADHD could be tantamount to abuse. Do I feel that's too strong? I mean, one is abuse is certainly a loaded term. I would argue it's probably an overused term in today. So I would classify harmful as maybe different from abusive. So abusive is implying that harm is just acknowledging that there is potential damage happening. Abuse contains within it the implication that the reason or rationale for this going on is not just ignorance, it's not just chance, it's not just even emotional outbursts, but that the perpetrator of the abuse is getting some reward, some enjoyment, some purpose or value out of inflicting damage on others. So I think in that sense, abuse is probably too strong. I do have a video out about, I think it's titled, Do Stimulants Harm Your Brain? And again, we have more than 30 studies indicating comparing kids who are treated with stimulants to kids who are not treated with ADHD, comparing all kids with ADHD or a population treated with stimulants versus a population not treated with stimulants. And the evidence suggests that the kids treated with stimulants have brains that look more normal. Now we can debate, and that's normal in terms of anatomical structures, it's normal in terms of activation patterns, it's normal in terms of connectivity patterns. Do we need more research? Absolutely. Do we need more long-term research? Absolutely. And it's not completely clear how much benefit that has in terms of functional living. But I mean, in other areas separate from neuroanatomical, we do have, there is evidence that rates of substance abuse are substantially elevated in the ADHD population, but being placed on stimulant medications, particularly earlier in childhood rather than late in adolescence, has substantial protective effect. So, I mean, does that mean every kid with ADHD should be on medications? Absolutely not. But on the whole, as a public health measure, probably more kids being on medication is avoiding some long-term problems that can be preventable. So Michael is commenting on Dennis's comment that he liked what Dennis had to say about people who live in countries that don't have access to prescription medications. So Michael suggests that I could do a video on treating ADHD without medications. So one thing you're not talking about is I do have some video on biofeedback. I have some video on video games. So there's evidence there. That's probably not the direction we're going, because particularly biofeedback and hooking people up to an EEG is probably less accessible if you don't have access to medications even. So I do have a talk on cognitive behavioral therapy. There's also extensive work on family therapy that helps with ADHD, because again, a big part of ADHD is the support and structure around you and providing that in an adequate and appropriate way, and essentially enforcing authoritative parenting rather than authoritarian or too lax or negligent parenting. So authoritative means you set rules, you set expectations, you empathize when someone isn't meeting those, but you have consequences for them, and you help the person achieve that. Authoritarian is setting sort of arbitrary rules that are arbitrarily and harshly reinforced and punitive, and that measurably is not too good for not just people with ADHD, but not too much of anyone. And the other extreme as well, lax, negligent, absent parenting, where you don't set any rules or expectations and don't follow up also is not a good recipe for raising most kids, but particularly kids with ADHD. So I, again, do have a talk on CBT and ADHD on this channel. So that may be a good place to start, particularly, well, two different things. Lots of CBT can be self-taught. I think in the setting or context for ADHD, it's extremely hard to self-teach it. And by that, I mean, I've helped people with panic attacks. I've helped people with depression using CBT techniques, which they could master themselves and learn and practice on their own. Given that CBT requires or involves doing repetitively really boring, not particularly interesting, or in the moment even seemingly that relevant exercises, thought exercises, and involves lots of detailed observation of what someone's doing and what triggered them, both of which are areas where people with ADHD are likely to not do well on their own. So giving someone a CBT-based manual for ADHD and say, here are all the answers. I've worked with lots of really bright, really motivated individuals with ADHD, and they will say, oh, I have 4 different ADHD self-help manuals in my shelf. And I bought one and I looked at it, paged through it and said, oh, that's a really good idea. Oh, that one, I'm doing that one already. Oh, that one is not that relevant. Oh, here's another, I really should be doing this. And they might do it for a day or two, and then they put it aside and they don't stick with it. So CBT for ADHD is clearly best taught either with a therapist or a small group format. Maybe someone out there has devised ways to self-teach it, but I haven't seen one that works. So Michael also points out that natural treatments for ADHD are often criticized, but for many people in the world, that's the only alternative. So again, worldwide, the biggest, most commonly used psychoactive substance is not alcohol, it's actually caffeine, and presumably some percentage of those people are self-medicating ADHD. I mean, part of it is that even though caffeine is so ubiquitous, and I do have a video on caffeine, at a sort of dose for dose basis, an equivalent dose, it's a poorer stimulant than our dangerous things like Adderall and methylphenidate. And why I say it's worse is that there's more tremor, there's more cardiac side effects at an equivalent dose. The answer is we're usually using it at a much lower effective dose than we would use a stimulant, a prescription stimulant. And at least from my direction, but lots of the other criticism is that some of these things may work, but they also may not work. And given that in medicine in general, there are certainly placebo effects, and certainly in mental health treatments, there are very large placebo effects potentially, it can be hard to sort out. Was the person just thinking that saffron helped them to function better and that provided the motivation, or I sort of strongly support or encourage not encouraging substances for which we don't have a good body of good research, because I've seen placebo effects, strongly affect people in the mental health field. And I've seen practitioners who were convinced from 1 or 2 cases that drug X had this property or drug Y had this bad property, which clearly study after study showed was not a real issue associated with that substance. It was just the connection that doctor made. And then they might have even told their next 3 patients, oh, this drug will either help you with this or this drug is going to cause this side effect. And then they got those same things that they created. It's not just an observation bias or a confirmatory bias, as they actually created the situation to confirm it. Or they promoted the likelihood of a confirmation because they added to it with the placebo effect, let's say. So Max asks, can we detect mental health conditions in animals? You've noticed before ADHD symptoms in mice studies, but can they actually meet ADHD criteria? How about depression or other conditions? So what I would say is all of what we're doing in research are models that are imperfect, and that includes whether we are talking about dopamine circuits in the striatal region or an animal model. We're trying to make approximations. We are oversimplifying what's really going on in actual human brains. And a model is only helpful to the extent it has some relevance and some predictive powers. So I do think that with ADHD, one of the central features is hyperactivity, and I'm still amazed at how many people who are, as I'm sitting here shaking my legs and people can see that my body is twitching. I don't think I have ADHD. I think for me it's more anxiety, which actually doesn't happen when I'm talking with individual patients. It's when I'm presenting. Anyway, physical behavior is something that's fairly easy to quantify and measure. And some of the basic circuitry in animal movements and human movements do seem to be the same. And drugs that have effects on animal hyperactivity tend to have effects on human. Not always, not all situations. It's not identical, but I do think there's some usefulness to that as a model. Can we ask? I mean, the nice thing is that all the ADHD symptoms are observable behaviors, but what's the equivalent of interrupting someone when they're talking? I mean, mice communicate vocally, but we don't know enough about their vocal patterns to even know what an interruption would look like. And situations like getting up and walking when it's inappropriate. When is it inappropriate for a mouse to be walking around? So clearly some symptoms don't translate at all. Others, maybe if we were more astute animal behaviorists would. And I think with depression, I think there's some validity to learned helplessness models essentially an animal is shocked and can't avoid it and looks down and despairing and takes less action to initiate or improve their situation even when given the opportunity. So there seem to be some superficial parallels, or even beyond superficial, but how deeply they go, certainly they're not completely. Can we distinguishing between just sadness and depression in a human is difficult enough, but in an animal model, that's really going to be a challenge. Michael asks, what are the biggest differences between the left and right prefrontal cortex? I'm not going to answer I'd say the single biggest difference, I would say, is in most right-handed humans, most of the language, the Broca's areas and Wernicke's areas are on languages strongly lateralized to the left. That's the biggest consistent difference and the easiest to define. There are other approaches looking at general mood, looking at general tendencies to approach or withdraw from situations. I guess I'm just going to defer to I do have a left brain, right brain talk. So inspired by Ian McGilchrist's work. So Ian Gilchrist does have a YouTube channel where he discusses many of his observations and research on left brain, right brain differences. I'm just going to leave it at that. There are studies looking at either stimulation or inhibition or activation of left or right prefrontal cortex, and which is more beneficial in ECT, electroconvulsive therapy, for treating severe depressions, or which is more effective in transcranial magnetic stimulation. So I think we will learn more the more we keep exploring. So Max asks, do I think there's an argument for low-dose stimulants like methylphenidate to be as normalized and accessible as caffeine? So I'm not clear whether, if you're asking low dose versus low potency, what I would say is if you make a low dose, if you make only 1 milligram of Adderall available, people who want it are going to go buy 100 of them and take 100 at once. So if you're talking about low potency, so even something at high dose may not be that powerful, I'll step back, and I think I'm not even sure what the best social policy is regarding alcohol or the drugs we're currently treating as evil, horrible drugs. Certainly something like psilocybin seems to offer more potential for good and less likelihood for bad. Now, have people been harmed by psilocybin? Absolutely. Is it as likely to cause flashbacks or even permanent psychotic states as something as LSD or as ecstasy or cocaine? No. So part of it is sorting out normal, what are the risks of good? What are the risks of bad? And I don't think it's we quote tried prohibition and then gave up on it after a decade plus, and it was considered a horrible failure. But rates of people dying from alcoholism did drop during that period. So was that a public health benefit? Was there other crime associated with it? So I don't think we have a coherent approach, certainly in America, to substances in general. And one of the comments I found most insightful and interesting about the series Breaking Bad, which I guess it's several years old now, but all about the methamphetamine industry in the Southwest and the cartels muscling in on it, is that the DEA agent, the brother-in-law of the main character, and I'm white, forgetting the actor's name, Brian. Anyway, the DEA character, the brother-in-law who's investigating all this drug use, his hobby is homebrewing alcohol. And there's no commentary on that or no one discussing the irony of that. It's just put out there to help, I think, people think about how we treat these substances. So part of me at some time thinks we should be banning alcohol. We should be banning tobacco. Tobacco, except for maybe people with ADHD, has almost, yes, it can calm some people down, but the health risks of cigarettes are clearly vastly greater than the benefits at a society-wide level. So part of me thinks there's good aspects to the nanny state. Part of me thinks that there's good aspects to libertarianism and trying to make people as aware as possible the good and bad and let them make their own decisions. I don't know. What I see in society is so often it's not just people are making bad decisions, it's that people are given, particularly where capitalism can intrude, there's a huge incentive for anyone selling the product to misrepresent what the ratio of good to bad is. So that's what I'll say. So I don't, again, I didn't mention it in this video, but I have strong reservations about whether we consider